And we are live.
I'll give it 1 minute and then we'll get started.
Yeah. So I think we had about between 25 and 30 registered, but so this is pretty good. So we're doing pretty well, given the likelihood of drop-offs for various reasons.
Okay, it's just turned 1 o'clock, so I think we'll get started if that's okay, because there's quite a lot to pack in the hour. So for those of you who are sort of new or coming back to the primary care community, Q community, we are trying to launch a series of lunch and learn events, and this is the inaugural one. And the topic that we're going to be covering today is in fact very topical. It's about delivering immunisations within primary care. And we're very lucky to have Fazana Hussain join us today. I'm going to briefly introduce her. I'm sure most of you will probably know her from elsewhere and from being involved in QI. So Fazana is a GP partner in Newham. She's also a PCN clinical director. She's very active in the media and is a huge QI enthusiast. And she's been working on a drive-through childhood immunisations clinic during the COVID-19 pandemic and has come to share her story with us. I'm going to hand over to Fazana now, but just to say, as people join the call, they will be on mute. We're going to take questions right at the end, so you can unmute yourselves and come in at that point. Go on. Thank you, Fazana.
Thank you so much, Ramya. Thank you for inviting me and lovely to be here for the inaugural event. Thank you everyone for joining us this afternoon. And as Ramya says, I'm a bit of a QI fan. I find that it helps me so much in my work, both as a GP partner, also as a primary care network clinical director, and also at home really. So I'm going to just go through some of the basic techniques I used, just a bit of aim setting, process mapping, and the plan, do, study, act cycle. And Ramya, thank you so much for helping me with my slides. In true Chris Whitty style, I'll be asking for the next slide, please. So as Ramya said, I'm a GP partner in Newham in East London, and sadly Newham has been one of the boroughs with the highest COVID death rates. And the drive-through childhood immunisations clinic really came about because I could see that as soon as lockdown started, our coverage rates for our childhood immunisations were falling rapidly. And I thought, crumbs, you know, we're in the middle of a pandemic where at that point we didn't have a vaccine, and we could see the resurgence of lots and lots of other infectious diseases. We already know that in South London there's been a little bit of a resurgence of measles. So I really wanted to do something about that with my team. Next slide, please. Thanks, Ramya. So it's what's affectionately called the muck immunisation clinic. So really the aim was to keep our patients safe during COVID while keeping our immunisation rates high, but also to keep our staff safe. So I work in an area in Newham where 73% of our population is BAME, and 80% of my staff are, my practice nurses, BAME. So it was really important for me to protect our staff as well as our patients. So no burgers or fries, but we could offer you in our muck immunisations clinic some protection against infectious diseases for your little ones. Next slide, please. So, as I've described briefly, the problem, parents and carers were just not happy to bring their little ones in. Perfectly understandable. Many, many people thought that GP practices were fully closed because the doors were closed. There was a national survey where more than 73% of parents said that they were not happy to bring their children in for immunisations because of the risk of COVID transmission. So really wanted to get those kiddies protected while keeping the face-to-face contact at a minimum. Thanks, Ramya. Next slide, please. So the solution. We wondered if it would be possible to have parents drive into the practice and for the nurse to actually administer the injection in the car. Of course, we know in Newham we're quite financially deprived and not everybody drives. So we wondered if we could actually do a drive-through and a walk-through. So we were classing buggies and pushchairs as vehicles as well. And the aim was to reduce the face-to-face contact from the 10-minute appointment to a 2-minute appointment. And that was by breaking up the consultation into 3 parts. So if we think about what our practice nurses do when our babies come and our preschoolers come for their injections, the first third or so is the explanation of the vaccine and what the side effects might be and checking whether the little one's got a temperature. Then there's the actual administering of the injection. And then there's quite a little bit of note keeping and writing up the child record, what we call the red book, and writing that on the computer. So we wondered if we could just break that up into 3 and do the first and the last part remotely and actually just have face-to-face contact for the actual jabbing of the child. Next slide, please. So here's where quality improvement was really useful for me. So I was fortunate to be trained by the NHSEI Time for Care team, and I did that core 6-day program in 2016, and it has stayed with me ever since. So we used a process map, and this took us 15 minutes. So the first thing I would say is, although we're quite used to using process mapping and it's become more normal for us in our team of 10, these QI methods, I think, once you're using them, they're not really time taking and they can actually save you a lot of time. So this was 15 minutes to create this, but it wasn't me that created it. The strength of the process map is, I think, having the key people in the room. So I had my reception manager, I had my practice nurse, my healthcare assistant, and myself, and we did this in 15 minutes. It would have been ideal to have a parent in as well, but we didn't have time for that. I don't know whether you can fully see this. It's a bit of a difficult picture, but you can see that the pink across here is all the problems. The yellow across here is each process step. The blue is ideas. And the green at the top is decision making. So a little example would be, and I have the original here, I have kept the original that stays with me. And, you know, you can pin it up on your practice wall or, you know, your staff room wall. Ours is stuck up in our groups room. And it's just really helpful to have people who are involved in the process, everybody, to just think about what the steps are and what the problems are. So my reception manager said, well, it's all very well for Zona thinking about a drive-through, but what about the people that don't drive? And actually, it's a new system. Do you think our patients will go for it? So it was really helpful just to plan some of that and think about some of the challenges that we might have. And then, of course, giving it a go. Next slide, please. Thanks, Ramya. So then we moved on to the plan, do, study, act cycle. We'd done our process map, and then we thought about what would this actually look like. So there was the reception, and again, I've got the real thing here. So again, just some flip chart paper is all you need, and you just need a couple of felt tips to write up, and then you can stick it up anywhere. So we had things like planning. Reception would ring every single parent and carer to ask them to come in at a certain time. There were no that and let them know that it was a bit of a new strange system, that we would ask them to park just outside the practice and that they would need to call us. So then we did it, and we realized that actually once you do something, there's lots of stuff that comes out that you might not have anticipated, and that's why the study bit is good. So we realized that a lot of our patients were not driving in, that lots and lots of people were actually bringing pushchairs in. So how could we keep them socially distanced? Now, we're fortunate that the practice building has a nice patio front garden just outside, so we were able to put some 2-meter social distance stickers on the ground and ask them there. So that's an example of how we did something and we realized we needed to make some changes. We studied it and then we acted. Thank you. Next slide, please. So I think I've really gone through this. The process that we used was that involving the whole team was really important. So having an administrator that was the designated immunisation lead who called everybody to say, this is a different sort of process that we're using, just so that parents and carers were aware of what was going to happen, because it was quite different. And then parents and carers on arrival, whether they drove in or whether they walked in, called us. Even though they were just outside the building, they called us to say, we're here. Our practice nurse would then phone them back from inside the practice to go through that first explanation that I mentioned, the first third of the consultation. She then would come out herself, but we realized that she needed an assistant with her as well to bring out the anaphylaxis kit, to bring out the sharps box, and to just be a bit of a help to her as well, because it's a new system, to just make sure mum or dad or carer felt comfortable. The injection would then be done in the back seat of the car. Positioning was important, or in the buggy itself. And then the records, and then the receptionist, the administrator and my practice nurse comes back into the building, where they actually write the records up without the face-to-face contact. And then we send that template off with our Accurex text system, so that parents still have the records that they can pop in their red book. So that was the system really that we're still continuing to use. Next slide, please. Thank you. And here are just some of the pictures. So with the Plan, Do, Study, Act cycle of studying it, we realized that we could invest in these nice little yellow stickers, which has proved really helpful. What do you do in the rain when it's cold and it's wet? And we found this with our flu vaccination campaign that we've been using the same model for. Well, we're fortunate that we have a little porch just outside our practice building, and you can see our nurse there, and that's heated and covered. So that's been really useful for us. That wasn't what we had originally planned to do, because there's less ventilation there, but it's good on the rainy, cold days. Next slide, please. And so I've spoken about how we actually did it. Thank you. Next slide, please. Some more pictures. So here's the nurse doing it in the back of a car, and here's the cars lined up just outside the practice. And the assistant is very kindly not only carrying the sharps box and the anaphylaxis kit, but also the umbrella to keep our nurse nice and dry. Thank you. Next slide, please. And as I've mentioned, so making sure that parents still had those records. Not all our parents felt they were able to transcribe and write in their red book. So we said, it's no problem at all. You can just have the computer template that we can send you with Accurex texting. So really thinking about using all our digital facilities to the best that we can. Thank you. Next slide, please. And another nice picture on our social distancing. That's our front garden, and that's the porch there you can see. Thank you. Next slide, please. And so, yeah, the challenges, so what to do on the rainy, cold days, and particularly we're finding that a bit more challenging with the flu vaccinations. But of course, our flu vaccinations, a lot of those people are adults, apart from obviously the 2, 3, 4-year-olds, which does make it easier. Positioning of the baby when administering injections in the car, we found the parents have obviously been really helpful there. And just thinking about patient confidentiality when there's a car behind and we're outside. So just thinking about all those things and making sure our voices are lowered and being aware that we are in an outside environment. And we did have to get CQC not registered, but just amend our statement of purpose. Although we were doing this just in our own premises outside, because it was outside the consulting room, there was a tiny change we needed to make with CQC to be compliant. Thank you. Next slide, please. And here's some parent feedback. So I've got permission from Mrs. Abida Sultana, who's the mum of one of our 3-month-old. And she actually said, I'm so happy you kept my baby safe. Nobody knows what people are carrying inside a practice waiting room. I didn't want to go in, and I wouldn't have brought my baby if I had to sit in your waiting room. I know that the doctors and nurses are taking the risk for us. I feel like I and my baby were protected, and now I can bring my baby for the next appointment. Thank you. So I know that she would not have come in for those childhood immunisations if it had been our old model. And I'm really pleased to say that even in what I call the COVID quarter, the one that was April, May, end of June, quarter one for 2020, we managed to hit a 92% for our 0 to 2s, and we're at 88% for our preschool boosters, which I thought wasn't bad going compared to the first few weeks where our coverage had gone right down to 25% of our patients that we were expecting to come weekly. Thank you. Next slide, please. Thank you. That's it from me. Thank you, Romeo.
Great, thank you so much, Fazana. It's been really sort of insightful to see how you've used your QI tools to maximise the impact of these clinics and to mobilise something really quickly as well. In all the excitement, I actually forgot to introduce myself, so I'll do that now. So my name's Romeo Matthew. I'm a GP and I also lead a quality improvement team at Islington GP Federation. I do this alongside Tamar Koch, who is going to be co-presenting with me today. And we're going to be talking on a similar but slightly different topic. So we have been working on delivering mass flu vaccination clinics during the COVID-19 pandemic, and we're going to be sharing our journey with you today. I want to start by giving you a bit of context in terms of how we ended up doing this work. So as a quality improvement team, our remit is to support practices within our borough with continuous improvement. And one of the areas that we have focused on an annual basis has been trying to increase or improve the uptake of flu vaccination across Islington general practice. And we do this by sharing best practice. So we look at what's worked elsewhere and we try and disseminate that learning. We also do a lot of coaching and facilitation with practices, help them to come up with change ideas, support them with the implementation and help them to think about how to make these changes sustainable. We also do a lot of work that focuses on using data to drive improvement. So during the flu season, each of our practices gets weekly data on their flu vaccination achievements. So how many patients they've vaccinated across each of the cohorts and how many more they need to do in order to reach their public health targets. But obviously in the context of the COVID-19 pandemic, it felt like we very much needed to rethink our role as a quality improvement team. A lot of the practices were reporting back to us that they were really going to struggle with delivering the flu vaccination programme this year. And as a result, we felt we needed to be a lot more involved. We needed to be co-producing and co-delivering the flu programme alongside them. And we actually saw that there was a real opportunity here. It was an opportunity to bring QI to the fore and to fully demonstrate the impact of it. So like I said, our usual sort of approach is to come up with recommendations and to support and coach, whereas actually this was a chance to be much more in the driving seat. In terms of our work, we tend to use the model for improvement to make sure that we've answered these key questions around what is our aim, what is it that we're trying to achieve here, how will we know that a change is an improvement, and what change might actually result in an improvement. And if you ask us what our global aim was, I think it would be to create capacity for vaccine delivery across Islington general practice. We wanted to make sure that no Islington resident who wanted a flu vaccine this year would miss out. And in turn, that would hopefully prevent a spike in flu cases and would prevent any undue pressure on our local healthcare system. In terms of a change idea, we knew that it had to tackle these two big underlying issues that practices were reporting to us. The first being around workforce and the second being premises. So in terms of workforce, particularly at the beginning stages of the pandemic, there were lots of staff members who were either shielding or they were having to go into self-isolation or household isolation. And this was having a big knock-on effect in terms of workforce. And actually it seemed to be particularly affecting nursing workforce who would provide the bulk of, the flu vaccination campaign and be delivering that. And then in terms of premises, so we know that there's a whole range of buildings that we use in general practice. So some practices operate from very small sites that are based on a high street and others are in large multi-purpose buildings. And it was these smaller practices that were airing concerns about how they would do this. How would they bring in several hundred patients while social distancing requirements were in place? So the solution that we came up with had to address these. And in the end, we decided that actually we needed to put on flu clinics in a mass venue, somewhere where we could vaccinate a lot of patients in one go. It had to be a site external to the practice that would allow this sort of throughput of patients. And we also wanted to use a pooled workforce to make sure that we were achieving population coverage, and we wanted it to be a real collaborative effort. And one of the benefits we saw of this was that making the sort of use of the economies of scale that would come alongside this. In terms of our measures, we wanted to know that patients would book into these clinics, that they would attend, and we also wanted to get some sense of what the patient experience was like. These are just a few of the key features of our model. So I mentioned already that we wanted to use a mass venue or mass venues where we could vaccinate many patients in one sitting, and also practices could all work together within each of these venues. We were fortunate enough to be provided with event space by Arsenal in the community, who gave us access to their hub building. And we were also provided a separate event space by a local sixth form college. And this was leveraged by our integrated care system. And they also gave us access to people from the voluntary sector who stewarded the events and made sure everything ran smoothly on the day. I think very early on, though, we recognized that these mass clinics weren't going to be suited to everybody. And we needed to identify a target population who would be best suited for this sort of approach. And in our minds, it felt like this would involve focusing on the younger, more mobile population, people who were probably under the age of 65 with fewer long-term conditions. So we set up computerized searches and invited patients accordingly. We also made a decision not to mix children and adults as well, because we thought it would be difficult trying to maintain those social distancing measures in that sort of setting. Each of the clinics had quite a large capacity, so it was ranging from about 650 to 750 patient slots at each of these clinics. And we're quite the small federation with limited resources to do this. And we knew that we were never going to be able to take that volume of calls from patients to book into these clinics. So we had to set up an online booking platform. So patients all got text message invitations, they got a link to a website, and then they were able to book in online. And this is how we sort of did the recall at scale. We wanted practices to do this collaboratively, and that meant sharing vaccines, it meant vaccinating each other's patients. And to keep things fair, we asked practices to provide a pro rata workforce contribution. So smaller practices contributed fewer hours and larger practices contributed more. So we spent a lot of time planning. It was quite an undertaking to put these clinics on. And I want to go through some of the opportunities and also some of the challenges that we face. So in terms of opportunities, it was a chance for us to really test the scope of integrated working, and for practices to also get a flavour of what it was like to set out on a venture like this alongside their peers. We were able to really harness the power of digital technology here. So like I said, patients were all booking online, and actually this made it much easier and quicker. And this was reflected in our patient feedback as well. So essentially within 2 clicks of a button, they'd book their flu appointment. Unlike the kind of usual processes, which involve patients having to hang on the phone, often for 15 to 20 minutes. And I guess it's also important to say that because there were a cohort of patients who were able to do this digitally, it allowed for those who maybe don't have access to a computer or who would prefer to just call in and book in it at their own surgery. It allowed capacity for that within the practices, so the phone lines were freed up for that. The booking platform also gave us access to to analytics. So we were able to track the uptake of bookings on a daily basis and be very responsive to this. So we could see if there was any disparity among the practices, whether there were particular practices who were underrepresented, and then we were able to act on that data and do some really proactive recall. Likewise, we did the same for underrepresented groups, which Tamar will talk about shortly. As an organisation, I'd say that we sort of could see the real value of doing this work, and it allowed us to bring the sort of best of our skills from across the organisation. So it's a real collaborative project, even on an internal basis. So we saw the IT team, the analytics, the quality improvement team, operations, all working together. And I think we were all quite passionate about this because we could see the benefit for both practices and their patients. There were, however, plenty of challenges. We were obviously trying to do this in the middle of a pandemic, and that meant that we were working in a rapidly evolving situation, and there were many moving parts. I think most of you working in general practice will recognise that there was a real transition in the early months. So in the beginning stages, I think there was a lot of nervousness about bringing patients in, familiarising ourselves with all the infection control measures and so on, but practices built their confidence in that. And actually, a lot of practices who thought they couldn't do this on their own at the beginning, then changed their minds and said, actually, we can, and they felt more confident. I think some of them developed cold feet as they went along, because they were worried about whether or not their patients would actually turn up to these hub-based clinics. And then they wanted to avoid that situation where their patients weren't getting vaccinated, and also avoid the situation where they would potentially lose out on income if their patients didn't turn up to these clinics. So 21 practices signed up in the beginning, but only 9 made a commitment in the end. And the final thing to say about challenges was that we were trying to do this on an integrated basis, but the levers to support that type of working just weren't in place. And it's difficult when you're trying to do this on your own. So there were challenges around coordinating vaccine supply and delivery, choosing dates that would suit all the different practices. The requirements for CQC registration only became apparent kind of further along in the journey. And then there was difficulties around technology. So yes, we were able to kind of use a digital platform, but nothing that was available tied in with existing primary care IT systems. So we had to put a lot of resource into transferring all the patients who had booked on this platform then onto a primary care IT system. So yeah, that's just a quick summary and overview. And I'm now going to hand over to Tamar, who will talk you through the more specifics of our QI journey.
Thanks, Ramya. So the first aspect of the implementation of the model that I'm going to talk about is the call recall strategy. We composed SMS text send out to patients to invite them to book their appointments. And we wanted to do this using behavioural insights theory. For those of you who might not know about behavioural insights, it combines lessons from psychology, from cognitive science, and from behavioural economics to help us understand how people behave and how they make decisions in everyday life. So we know that behaviour is often influenced by automatic responses or rules of thumb that we have kind of ingrained in us, even at a subconscious level. And if we can target these unconscious biases that we have by changing the context or presenting choices slightly differently, that can result in impactful changes in behaviour. So we use different style messages to different randomly selected cohorts of patients. For example, we composed a message to emphasise COVID safety and best practice of infection control to patients who might be more mindful of that aspect of the clinic. We adapted a public health message to which sort of targeted people with a more pessimistic view of life or of the situation, emphasising the risks of getting flu, with the statistics of deaths and hospitalisations from flu, hoping to appeal to their sort of desire to prevent that. We composed messages which highlighted the correlation of those at risk of COVID with those at risk of flu, appealing to the cognitive bias of needing to act fast. We also know from evidence and literature that sending messages at different times of day can have different impact in terms of uptake or action, knowing that the messages that go out at lunchtime or the early evening have the most impact. In fact, most of our messages went out in the early evening, and the last one went out at lunchtime. All in all, we sent 8 texts to patients who are at the Emirates or the Arsenal Hub. Those were at 6 practices, and 6 texts went to the patients who were attending the other sixth form college site. The first site, we ran 3 events, and the second there were 2. And as Ramya has intimated, we could use the booking platform to regularly review the bookings on a daily basis and adjust our approach accordingly. Actually, in the end, it transpired that it was too difficult to determine whether particular style messages had a particular impact, because often we ended up sending messages consecutively or very close to each other, so it was difficult to tease out which one had the biggest impact. This is a chart that shows booking activity at the Arsenal Hub site, where each different colour line denotes a different GP practice, and the arrows show when the text was sent. The dark blue arrows show when text was sent to the whole cohort, and the yellow arrows and the red arrows were specific messages that we sent as a result of looking at the data. So you can see the text message correlates with a peak of activity, and as one might expect, obviously the greatest activity happened at the beginning of the campaign, with smaller peaks thereafter. So we responded to data. We saw that there were some practices who had a lower uptake in terms of booking, and we wanted to try and broaden the reach of the invitations to try and get as many of those practices patients to book in. So, for example, one of the things that we did in the lower uptake practices is we sent a text to all of their shielders, asking them to share the text with household members, that group of household members of shielders being a newly eligible group for this year's flu campaign. We also responded to patient feedback. So we began to hear from a few practices that patients had phoned them up, questioning the provenance of these texts that they had received. And so we started by sending what we called a warming message, which was a text message explaining to the patient that in a few days' time they would receive a second message inviting them to the flu clinic. So they would expect it and understand that it was a genuine invitation. We also realised we needed to optimise all our resources, and also help the practices take responsibility for booking in their own patients. And this also meant that they could support patients who perhaps struggled with digital access, didn't have email or internet, which was required to make the booking. One of the big things that we really wanted to do was try and tackle health inequities. We know that from looking at the data that people from minority ethnic groups generally over the years have a lower uptake of flu vaccination. So we wanted to see what we could do to tackle this. Also, from sort of observational evidence from the first clinic, we could tell that people from minority ethnic groups and non-English speakers were underrepresented. So we tried to think of ways that we could tackle this and improve uptake. One of the first things we did was we created a search to identify patients who needed an interpreter or had English as a second language. We identified the top 5 languages spoken in Islington as being Turkish, Somali, Arabic, Bengali and Spanish. And we got the messages translated into these languages and sent them out to that group of patients. Unfortunately, that was not very effective. The data showed that between 5 and 11% of those patients went on to have the vaccination, depending on which practice the patients belong to. We also created a search to identify people from minority ethnic groups as coded in their GP records, and our call handlers then went through the list and called these people individually, extending an invitation to them by phone as well as by SMS to try and improve uptake within those groups. Thank you. So on the day, we made continuous improvements to the processes on the day. For example, we found that the IT was very slow. It was always going to be slow using the system that we had, but it was especially slow for the first hour or two of running the clinic each time. Our IT team did some analytics and worked out why that might be, and there were technical things that we could do to try and speed up that process, which we then implemented. The following clinics, like using dummy patients to load up the systems and just loading them up earlier than we had planned. We also found that patients who came to the clinic who weren't booked into the system, it would take quite long to get them booked in. And so we identified one station, which we designated as being the station to deal with those patients, and that helped speed patient flow. We realised that in order to maximise time before the clinics on the day, it would be more efficient to induct the stewards if we could the night before, and so we started to do that. That was very helpful. And we realised we needed some contingency planning in case there were failures of the primary care IT systems and patient records. So we needed to work out a way of getting an emergency list of patients so that we could still press on and vaccinate people on the day, even if the IT failed. This sort of then created a flurry of information governance kind of activity and permissions, but we finally kind of got that signed off too. Thank you. So in terms of outcomes, there were 2,426 appointments available. Capacity in the clinics was a bit larger than that, but so this calculation, or the denominator, is based purely on kind of workload that the practices were able to commit to in the end. Of that number, 89% of the appointments were taken up, and finally 72% of the target number were vaccinated. Each clinic had a 20 to 30% DNA rate did not attend. The patient feedback was resoundingly positive though. 880 patients out of 893 said they'd recommend the service to friends and family, and we also got resoundingly positive feedback on patients' experience of attending the clinic appointment, also of using the booking system, and their views of COVID safety.
I'm just going to come back in to do the final slides here. So this is the million-dollar question. Did we achieve our aim? And this is data from last week. So it's practice performance in week 13 of the flu season, and we've compared 2019-20 data versus 2020-21 data. And we've got the individual data for each of the 9 practices, and then the final column that you can see on the right is the pooled data across those 9 practices. And you can see that achievement is up by 2% compared to last year. I would caveat that by saying, as most of you probably already know, that flu vaccination uptake is up across the board. However, these 9 practices were practices who all had particular sort of, they were vulnerable for one particular reason or the other, whether that was workforce or premises. So I think it's still quite an achievement that in the midst of a pandemic, they've still managed to improve their flu vaccination performance despite those difficulties. And then finally, I want to just give you a summary of our learning. So what I'd say is that practices, I think, really relished working together. They could see the value of coming together around an important issue like flu. Patients were happy with the hub model. They booked, they attended, they fed back very positively of their experience. We were able to really kind of use the analytics in a very powerful way, both to drive improvement, but also to address some of the inequalities. Our strategies to improve uptake in people from minority ethnic groups, however, was probably lacking. We did make an effort in terms of sending out language specific invitations and doing some targeted recall. But I think actually you need to be much more innovative in your approach if you're thinking about addressing health inequalities. In terms of, some of the difficulties, like I mentioned, the system was not set up for integration, and this was across a range of areas, from vaccine supply to workforce issues, to recall, to the IT and so on. And we ended up spending a lot more kind of time and resource and cost than we had anticipated on this. And also we were doing a lot of things for the first time. So it was the first time that practice was working together in this way. It was the first time we were working with external venues, with partners from the third sector, first time we were using a digital platform. And actually, I think this really did test our resilience. But overall, I think sort of passionate about it, they pulled together and we were able to deliver what we set out to do. And I think given where we are now and with the COVID vaccination programme looking like it's just around the corner, it's actually set us up to be in a really good place to learn from this and to implement some of that learning going forward. And we wanted to obviously use this opportunity to share some of those insights with you here today. So I'm going to wrap up there, and then I'm going to hand over to Brian now, who will take questions, and you can all just discussion as well. So I'll pass over. Thank you, Brian.
Thanks, Ramya. Thanks, Tamar and Fazana too. There's some really interesting kind of insights there from different parts of London. So I'm sure there's a lot of issues and things that people want to comment on. So, and also to get people's kind of reflections on their own experiences as well, and how they compare and contrast. That would be really, really interesting. So in terms of questions, I think there's two ways we can do it. If you want to put anything in the chat, that's great. But also, if you just want to raise your hand through the video, to keep it kind of an old school approach, that's fine too. Or if you want to kind of raise your hand via the participants button. So over to you. Any immediate kind of questions? Perhaps I'll just kick up while we're waiting for people to have a think. Just one question from me. I mean, I think the really interesting thing is about confidence building here. And I think just a question for all panelists. Do you see kind of evidence of people using the skills they've developed here because you're using something the first time that then take on to use in other spheres, in other parts of their kind of work? Because there's been so much kind of interesting learning and experience from this.
I have a question.
Yeah, hi Rita.
Hi, it's for Rami and Tamar. We do work together, but just thought I'd ask a question as well. So with the 50 to 64-year-old cohort, and obviously now you've got the learning from the at-risk sort of cohort, the prioritized cohort that you've already done. What do you think you're going to do differently next time, if of course we're going to do the 50 to 64-year-old cohort? And because you said there's probably too many firsts initially, so what do you think you'll probably scale back on with the firsts? Or
That's a really good question, Rita. I think we would probably be more measured in our approach in terms of the number of things we were trying for the first time. I guess in a way, if we were going to do the 50 to 64 cohort, it's almost like a second cycle. So we can use a lot of this learning. I think we would have to be really careful about how much time, effort, resource was being invested in each of these areas. Whether that be recall or the IT or the clinic support that was required on the day. I think some of that in terms of, I think there's sometimes the assumption that things work a certain way in practice and you can kind of lift that up and take it to an integrated model. But actually, it's a completely different ball game, and you can't just lift those things and directly transfer them to a hub-based model. And everything requires a lot of planning, a lot of support, a lot of hand-holding. And I think if we were going to do anything like this again, we have much more awareness of that, and we would be much more mindful of the sort of time and resource investment that is required.
Thanks for that. Just to add, I think 2% improvement on overall vaccination rates, considering all the challenges, I think is absolutely amazing. So well done to you guys on that, and the whole team that was involved. How many of those 9 practices have expressed interest in support, like going forward with the 50 to 64-year-old cohort? Because I know, like, feedback that I got from the team, like working at the event, everyone was really, really positive. They enjoyed that kind of integrated sort of way of working. And equally, it's helped with challenges such as space and workforce. So yeah, just going back to my original question, how many of those 9 have like expressed interest?
I think from memory, most of them have. There are a couple who haven't, but most of them have, because the same challenges that they faced at the beginning of the pandemic,
Still there.
to do with the social distancing, remain. The only other thing I'd add to Ramya's answer to your question was the issue of integration. I think, you know, integration is best done as a co-produced model, and perhaps because of the speed that we had to sort of operationalize this, we as the Federation took the decision that it would be, you know, be a good opportunity to test out doing things on an integrated way. I think if we had our time again or going forward, we might be able to sort of spend more time as a team with the practices. I know sort of these words, co-production and collaborative working, are sort of bandied about, but I really think we need to do more engagement work with the practices and come to a co-produced agreement and understanding of what integration means, to what degree, and how we operationalize it, rather than a hub and spoke model where practices sort of, you know, I think it would have worked better if practices were communicating and collaborating more with each other as well as just with us. And for me, that would be the gold standard. And if we could move towards getting practices to work at that level, that would be amazing, and I think also more effective.
Thank you.
Great. I think we've got a question from Adrian in the chat. How's your experience influenced preparations for the COVID vaccine trials and rollouts? I think that's a question for everyone.
Fazana, do you want to take that first?
Well, thank you, Adrian. Obviously, wonderful listening to Ramya and Tamar's work, because it shows the difference and the challenges in when you're trying to scale something up. For me, it was on a practice-based level, which is why I think have had some of the success we've had. The COVID vaccine delivery, Adrian, obviously must be done at least a minimum grouping of primary care network size because of the vaccine and the sites. So we'll probably be going through a lot of what the GP Federation in Islington has already done. As Rita said, I think that lots of lessons, but gosh, so much success, because so many things to think about with COVID, from who's doing the recall, where's the workforce, where's the IT, how do we join all that up with the non-primary care parts of COVID vaccine delivery. So lots to think about. But in terms of what we've done with the childhood immunisations at Project Surgery, I think it will be a completely different model.
Thanks, Adrian, for the question. I think my reflections on it, having done a sort of hub-based model for flu, is yes, it's doable for primary care to deliver the COVID vaccination programme, or at least in part, but it needs to be adequately funded and resourced. I think it's got a slight sort of increment compared to what the flu vaccine payments are usually, but actually, if you think about all the kind of things that need to happen in terms of like back office functions, the new bits of like that we need to operationalize, the coordination that is required across practices. I think there's a lot of unanswered questions there at the moment. And from my perspective, having gone through this, I'm still trying to lobby kind of at a regional, national basis that for all of these things to be considered and thought about. And it can't just be a sort of open-ended ask to primary care to fix all of these problems, because that we are not going to be able to do this on our own. And I think the two things that fundamentally need to be sort of thought about are the recall. How do we do this? How do we get sort of 1,000 patients booked in the space of 5 days, for example, with the Pfizer vaccine? And also, you know, like the IT system, what are we going to use? How is that going to work? And also, how do you get the workforce in place for this? What are we going to stop doing to enable us to do all of this? So I think there are a lot of questions. I think our learning has helped, but there are things that I think are out with our scope as well, and things that we can reflect on having gone through this and feedback to the system saying these are things that need to be addressed.
That's really helpful, thank you. I think, Ramya, in your presentation, you touched on the idea of the difficulty or maybe unexpected challenges around sort of integration or the flip side, fragmentation. I'm just kind of interested if you could maybe speak to that as well in terms of coordinating what's going to be a large-scale rollout.
Yeah, I can give you like a specific example. So one of them was around vaccine supplies, and so I think this year there has been sort of increased uptake in flu vaccination, particularly for those under 65. And we obviously set the events, and we assumed that practices are all going to have the vaccines. And when it came to it, they often didn't, and then there was lots of last minute scrambling around trying to get that vaccines in place. And then the other issue again was around the recall. Despite a sort of we sort of searched far and wide for a suitable recall system, and in the end had to sort of develop our own, which had lots of strengths, but the fact it didn't tie in with primary care IT. So there is nothing, as far as we know at the moment, which allows practices to book in online that syncs in with primary care IT systems. And that again was just meant that we were putting a lot of extra resources. Essentially everybody who booked in on this online platform had to then be transferred onto EMIS, which is the system that we use within Islington. And then the actual IT, itself was extremely sort of slow on the day, especially in the beginning. It warmed up, and we did manage to keep to time, and actually patients weren't waiting very long, so it all worked out okay in the end. But it wasn't without challenges, I guess is what I'm trying to say.
It's really helpful. Thank you so much.
Great. I don't think we have any further questions in the chat. I can't see anyone else's hands raised.
Right. Can I just ask Sally as well to come in? Because Sally has been doing drive-through clinics for flu. It'd be good to hear about your experience, because you said that it had been a real success.
It was a real success, thank you. Yeah, again, it was for our PCN. So we have 8 practices in our PCN, although one of them is a specialist practice for patients who are homeless or asylum seekers. So from the outset, they said they'd support the process, but probably none of their patients would be able to access the drive-through. It worked really well. Again, lots of first time all of us working together to deliver anything. So certainly there were some practices who jumped at the chance and some who held back that little bit more. We were able to share deliveries of flus because, like you said, they all come at different times. So that meant that we could prioritise the more vulnerable patients being seen quicker. I think what was really underestimated was the amount of support time this required, the planning, the meetings, the shopping for the bins even. You know, all those things that went into it that really weren't funded by the CCG were underestimated by the PCN because this was something new we hadn't done before. And so anything new like this, I would definitely go in with my eyes much wider open about how many sleepless nights it was going to cause and how much extra effort than what was actually on paper.
That's really interesting, Sally. It definitely mirrors our experience as well. I think, yeah, like you said, it's good to be in a place where we're going in with eyes wide open second time round.
Yep.
Any final questions or comments from anyone?
Yeah, I would just like to make a comment, I guess. So first of all, I'd just like to say that it seems like an incredible achievement to have set up a huge hub like that. So I think people should be saying congratulations for that. But at the same time, I can see that it was a phenomenal amount of effort. And so my take-home message for that is a lot of the purpose of doing that is a proof of concept. And as you said, like a lot of the reason it was so difficult is because you had so many firsts there. And so my question is, having done it this time round, where do you see are the areas where we can use collaborative working like this going forward, and what areas of general practice do you think would be suitable for these kind of models of collaborative working and hub centres?
Thanks, Will. That's a really good question. I mean, I think we have talked about whether this was the beginning of the future of flu vaccinations going forward, and I think it could be, because there are different ways you could do hub clinics. You don't have to do them in this very integrated way. You can do them in a much more sort of no frills way. And also, I think it sounds like from Sally, what Sally was saying, the PCN. If you have a PCN as a collective, rather than, we had sort of practices from different PCNs, different geographical locations across the borough, which I think get very different flavour to the integrated working. I think if you've got PCNs who are, the majority of whom are committing to working together, your opportunities are much broader. So I think the obvious services would be the vaccination services, but I guess there's a lot of joint things that we've thought about sort of in a theoretical level that PCNs could work on collectively, from, benzodiazepine and opioid withdrawal clinics, where also, I suppose, services where you're not relying on stock, because that's, again, deliveries, sharing of stock, individual payments, I think, make things more complicated. But if you're looking at sort of joint services to address particular cohorts of the population, that might be a bit more straightforward to operationalise. I don't know if Ramya, Fazana, Sally, you've got other ideas.
Yeah.
For me, the human factors, sorry, Ramya, the human factors of it, that we've built really good relationships in the network, and the trust we've built between us, I feel like the world is our oyster.
And I guess I'd just like to add, for those that perhaps haven't built great relationships, there are some enablers in the system. So as clinical director, I know that as the Impact and Investment Fund, the funding for the over 65 flu vaccinations and the target this year is PCN based. So it's in every practice's interest to reach the over 65, because the target is a PCN based target. It is not a practice based target. So there will be more enablers that will help PCNs move along if they haven't got the relationships that Sally's have, although that's the aim. But sometimes a project that is dropped in your lap can be something good to work on.
Yeah, well, I'd just like to say, I guess it's not so much about which projects are suited. I guess it's more about the journey itself. And what I found is that there was loads of really positives from doing this at an integrated kind of hub level. Like, talked about the kind of power of analytics that we were able to harness, the opportunity to address inequity, and also that ability to bring together loads of sort of high-end skills, whether that be in terms of operations or IT or QI, which I think is much more challenging on an individual practice level, because you're working with a much smaller pool of people. So in terms of concept, I think the idea of integration is right. I think we just have to be careful that to give it time for it to evolve, and also invest in sort of breaking down these barriers. And once we've done that, we'll be in a much better place to use this approach across a whole range of areas in primary care. I think it's sometimes just painful being among the first to try these things.
Will you be using the same model next year? Will you be repeating the process?
We don't know, because it all depends on what our practices want to do. So largely it will depend on that.
Great, thanks. I think we're almost out of time now, so should we maybe just quick wrap up and remind people about the next meeting coming up? Yes,
yeah, thanks, Brian. So we've got 2 more lunch and learn events in the diary. The first is on the 12th of January, again, same time, 1 to 2 p.m. And that's going to be led by Joanna, who is on this call, but I think had to go away to see a patient. She is going to be talking about matching capacity and demand in general practice, and some QI methods that she's used within her practice to do this. And then we've got Will, who is going to be doing a session in early February, I think it's the 2nd of Feb. Same time again, and is going to be talking about podcasting for health. I'm not going to go into the details of it, but I'm sure it's going to be a really interesting session as well. So I'll add those to the Q calendar and look forward to seeing you guys there. If anyone on this call isn't already a member of the Q Primary Care SIG, please do join so that you can sort of stay on top of these events and what's going on. And finally, so in the chat, I've just posted a link. So it's the bit.ly shortened link that you can see in the chat. And that's just to get some feedback on today's event, just to get a flavour of what you would like going forward so that we can build on this. So please do take the time out to fill that. It will take probably just less than a minute to do. And finally, thank you, everyone.
Yeah, thanks.
Thanks. See you all.
Thank you very much.
Thank you.